Okay, so we've talked about the anxiety disorders. Let's talk about the dissociative disorders here. Okay, the big one we're going to talk here is dissociative identity disorder, formerly known as multiple personality. Okay, so with the dissociative disorders, what we get here is a conscious awareness that becomes separated or dissociated from memories, thoughts, and feelings, and even the present awareness. In other words, the individual basically becomes separated from their past. All right, they become even separated from their current existence, such that they feel that their own actions are those of a different individual. All right, they feel that essentially they are more than one individual sometimes. Okay, so symptoms, they have a sense that things are unreal. All right, we've all felt like something was a dream. Okay, but that sensation has generally passed. With the dissociative disorders, that sense of things being unreal or dreamlike is persistent, it's consistent, okay? They have a sense that essentially they're separated from their own body, all right? This is like they're watching things from a different perspective that is not their own, hence that watching yourself. Now, like I said, the most common one that you need to know about is dissociative identity disorder, DID, formerly known as multiple personality disorder. Okay, a disorder in which a person exhibits two or more distinct and alternative personalities. Okay, and like I said, formerly called multiple personality disorder. This lady here, Chris Sizemore, classic example of dissociative identity disorder. Essentially, the way to look at someone like Sizemore is essentially you look at the brain as a house. Okay, and the house has many different rooms in it. Okay, and in each of these rooms, they live different personalities. Someone like Chris Sizemore may have upwards of 20 different personalities. So another maybe 20 different rooms, plus like a living room in the house. And the idea is that only one personality can come out of its room at a time. All right. So if you've got 20 personalities, only one can be in the living room at a time, and that individual is the one that expresses themselves. Okay. And while that individual is out and present, the other 19 individuals are back in their room. They're hidden away. All right. With these individuals, though, it can be rapid cycling. Multiple different individuals can come out throughout the course of the day. You can have individuals that have personality that align with who they are in terms of their age and their gender and their place in life. Or someone like Chris Sizemore, probably in her mid to late 50s, clearly of Caucasian background. Okay, she might have personalities like that, or she might have the personality that is a 17-year-old black boy from the ghetto. All right, so it can be a whole range of different personalities, but the idea is that only one exhibits itself at a time. Okay. Now, there's a lot of argument about whether or not this is real, okay? We did see an increase in DID in the late 20th century, okay? And the other thing we know is that DID doesn't exist in non-Western cultures, okay? So if we were to go look at people living in the bush areas of East Africa, in Uganda or Kenya or Tanzania or something like that, we're not necessarily going to find a dissociative identity disorder, okay? So then we're left with the question, because we see a rapid increase in the late 20th century, all right, because it doesn't necessarily exist in other cultures that don't share our psychological or social makeup in terms of their norms and values, does this mean that basically DID is a cultural phenomenon and not necessarily a biomedical phenomenon? All right. Is this a way for individuals who cannot handle the stressful situations of their lives to protect themselves? All right, is this essentially a defense mechanism? All right. So in other words, the critics argue basically that it's role-playing by a person who is open to suggestions by a therapist, or open to suggestions that this is a way for them to deal with the stress of society. Okay. The other thing is it could be a learned response that reinforces and reduces anxiety. So in other words, it could be a form of repression, essentially, okay, in which the individual is going to have different personalities that handle the scenarios that they're faced with in their everyday life slightly differently, all right? So this is one of them that probably has not been truly well explained in terms of the biomedical approach. All right, so let's jump ahead. Let's talk about the personality disorder. Remember when we discussed obsessive compulsive disorder, introduced you also to the idea of obsessive compulsive personality disorders. Okay, now there's a whole range of personality disorders. Obsessive compulsive personality disorder is just one of them that I mentioned. We'll talk about antisocial personality disorder here in a minute, but the idea is that, once again, it's enduring, it's lifelong, all right? It's inflexible behavior that has been present with the individual for a long period of time and which impairs with their social functioning, all right? So like I said, they're usually present also without anxiety, all right? So in other words, when a person is engaging in these inflexible behaviors, all right, they don't present anxiety. If you engage in an act, for example, that is not socially appropriate, okay, say you decide to rob a convenience store, all right, you and I, because we don't necessarily have a personality disorder, if we decide to go in and rob a convenience store, our palms are going to sweat, we're going to get somatic reactions, our stomach is going to crumble, and we're going to be afraid. Well, the person with a personality disorder, such as antisocial personality disorder, types of individuals who might rob a convenience store, they're going to do it without any fear. All right, they're simply going to say, no, I see the world in black and white. I want to rob this store because I want the money, and they'll go in and they'll do it without any anxiety, any apprehension whatsoever. Which brings us to antisocial personality disorder, okay? Now, this is more common in men than in women, all right? They simply exhibit a lack of feeling of consciousness, all right? They don't feel that anything that they do is ever wrong. They can engage in violent behavior. They can engage in very inappropriate behavior to family, to friends, to other members of society, and they simply don't see it as a problem, all right? We used to call these individuals sociopaths or psychopaths because of the type of behavior that they engage in without any apparent fear whatsoever, okay? But now we call it antisocial personality disorder. All right, so once again, returning to this idea of the PET scans, right, that we discussed earlier when we were talking about OCD. If we did PET scans of 41 murders, all right, oftentimes the thing with antisocial personality disorder is these individuals have an increasing history with law enforcement, starting when they're younger with petty crimes, and sometimes building up to things like murders, right? And if we look at PET scans of some individuals who are murderers who also had been diagnosed with antisocial personality disorder, what do we find? We find reduced activity in the frontal lobe. So remember, with our OCD patients, we have increased activity in the frontal lobe, which is that area involved in interaction with other individuals, high-level executive functioning, organization, and things like that, okay? These individuals simply do not have, and you can see on the PET scan there, normal brain on the left, we've got moderate activity in the frontal lobe, murderer's brain on the right, we have very, very little activity in the frontal lobe, okay? So these individuals don't have the same level of empathy and understanding of others as you and I normally would. And it says here what, in a follow-up study, repeat offenders had 11% less frontal lobe activity. So in other words, individuals who had gone to prison first time for some type of inappropriate behavior associated with antisocial personality disorder, and then released, okay, then they went back and they reoffended. These individuals had even less frontal lobe activity than others. All right, so here we can see with something like antisocial personality disorder, as opposed to something like dissociative identity disorder, that we can say it's an organic disorder because we have evidence from the PET scans. All right, let's jump ahead and we'll talk about mood disorders. Two major mood disorders I want you to know about: major depressive disorder or unipolar depression, and bipolar disorder. Okay? I mentioned before that depression is the common cold of psychological disorders. It's the most common thing seen in mental health practice. In an average year, almost 6% men and almost 10% of women report some form of depression worldwide. Okay, so it's very, very common. Now, but you got to differentiate two different things here. Okay, there's what we call blue mood versus major depressive disorder or unipolar depression. Blue mood is what you and I experience across the lifespan. Some days we feel bad. Some days bad things happen to us and that makes us feel sad, all right? But we overcome it, all right? We move on, we re-engage in life, we re-engage with our friends and our schoolwork and whatever, and family, and we go on with our lives, okay? That's blue mood. It's very common. Major depressive disorder, on the other hand, are those feelings of helplessness and hopelessness, but an inability to overcome them. Okay? So if we look at two comparisons here, two ways of looking at it, we could say that the blue mood is like you've gone for a hard run and you're gasping for air, but you're going to catch your breath eventually. Major depressive episode would be like having COPD. It's a chronic shortage of breath that you're going to have difficulty getting over. All right. So major depressive disorder occurs when signs of depression last how long? 2 weeks or more, and are not caused by a drug or medical condition. So what do we get? We get lethargy and fatigue. Who's ever felt tired? All of us. Some of us don't want to get up in the morning. Okay? We're tired. We don't want to get up for schoolwork. Do you know what? We drag our rear ends out of bed and we do it anyway. That is not lethargy and fatigue. Okay? Lethargy and fatigue is literally an inability to get up and get going. All right? It's so much tiredness that it overwhelms you. Okay. What else do we get with unipolar or major depressive disorder? We get a feeling of worthlessness, that you just are a worthless individual. All right. And life has no purpose. Life has no meaning, and the world would be better off without you. Okay. Now, once again, do we ever feel that way? Yeah, we feel that way sometimes, but we move on and we get over it. With the depression, it's 2 weeks or more. It's consistent feeling that way. Okay. Number 3, loss of interest in family and friends. And number 4, loss of interest in activities. In particular, this needs to be activities that he is interested in. So if they used to like to read books or ride bikes or whatever it happens to be, and they lose an interest in that, that becomes a sign of unipolar depression. Okay, let's talk about bipolar. Okay, bipolar used to be called manic depressive disorder. Okay, and basically, like its previous name suggested, it was a back and forth. It was a seesaw between manic, which is like uber happy, excited, I can take on the world, I can accomplish anything, like you're on drugs kind of approach type, versus the other end of the seesaw, the depressive, all right, which is similar to all the signs that we saw just a minute ago talking about depression. Life is worthless, I am worthless, I am helpless, okay? So it's an alteration back and forth between these two different extremes, okay? So there are some of the depressive symptoms we might see: gloomy, withdrawn, inability to make decisions, tired, slowness of thought, so on and so forth. We get elation, all right, constantly happy, euphoria, feeling that nothing can go wrong. They're very hyperactive. They have multiple ideas. They jump from idea to idea, and they want to constantly go. They have a desire for action. Now, frankly, during the manic side of the episode, these individuals are very entertaining to be around. They appear that they can accomplish anything, but the problem is they'll equally go back and forth between the depressive and the manic symptoms. Now, we have a special kind of bipolar called rapid cycling, where we move between depressive and manic rapidly, usually within a 24-hour period of time. Rapid cycling bipolar has a very negative long-term consequence. Those individuals are very difficult to treat and are more likely to have have comorbid depression, comorbid alcohol, and possibly suicide problems as well. Okay. All right, speaking of suicide, let's discuss it briefly here. Oh, I want to make one more mention really quick about bipolar. The thing about the bipolar individuals is that most patients are not going to be at the far extremes of the manic and far extremes of the depressive. They're going to be somewhere in between. And the idea with therapy is that we'll use mood stabilizers. So it's primarily a psychopharmacological intervention. We'll use mood stabilizers with these individuals to try to even out their mood. But the problem is a lot of them don't want to take the mood stabilizers because while they don't enjoy the depressive symptoms, they really value the manic symptoms. They enjoy being manic. They find that life is exceedingly happy when they're on the manic side of things. And so in one famous case, there was an individual that he agreed to, during the week, he would take some medication, all right, so that he could be stabilized, he could enjoy his relationship with his family and continue to work and things like that. But on weekends, he went off his mood stabilizers in the hope that he would experience manic episodes. He would experience these very alive feelings over the weekends. And sometimes that worked, and sometimes it didn't work. Not sure why his doctor allowed him to manage himself like that. Okay? Now, suicide. One thing I want to get across to you is that when we have patients who are depressed, all right, our biggest concern is that if we do not manage them successfully, that their depressive symptoms will lead to suicide. All right, now, two things to consider here. Most individuals who are suicidal, the big thing to be concerned about is not just the suicidal thoughts, because as we mentioned before, studies have shown that a significant portion of the population actually will have suicidal thoughts across the lifespan, but whether or not the suicidal thoughts have been raised to an actual plan. All right, do they have a plan? Do they have a means? Do they have a method? And do they have the ability to carry that method for suicide out? Okay. Once an individual starts to talk about specifics in committing suicide, that's when we become very, very concerned about those individuals, and we want them to seek emergency assistance. Okay. The other thing about suicide to consider is that a lot of individuals will attempt suicide the first time, all right, but they will not be successful. So in other words, they will intentionally harm themselves with the hope that they won't actually kill themselves. Why? It's a cry for help, because they feel that there's no other way for them to reach out for professional assistance. Okay, individuals who attempt but do not complete suicide the first time and do not receive the attention that they need have a very, very high probability that the second time around they will successfully complete the suicide act. Okay, men tend to commit suicide more oftentimes than women. Okay, women are more likely to attempt it but not complete it. All right, men are more likely to attempt and complete it. So there you go. The men are the clear finishers there, even in the arena of suicide. That's just a joke, maybe not appropriate. Alrighty, so what's the biopsychosocial perspective here in terms of mood disorder? So if you look at biologic, we know that there is a significant genetic there's a significant genetic factor that is going to be present here because mood disorders tend to run in families. The rates of depression is higher in identical as opposed to fraternal twins, all right? So it's not surprising that we see that there's a